as a society, we decide that, so we have patients with a cardiac condition that have an increased risk for sudden cardiac death.
Mm-hmm.
And of course, a patient that already experienced sudden cardiac death has a very high risk of recurrence, or at least that's what, as a society, what we think. And in that case, we cannot predict whether it is recurring, when it is recurring, how often it will recur, and how detrimental the arrhythmias will be. So the only way to protect those individuals is by giving a device that will monitor the heart rate and the heart rhythm continuously. And if the heart rhythm is completely normal, the device won't do anything. It will just sit there and watch the rhythm. But if an arrhythmia occurs that is malignant, potentially leading to a lethal event,
Mm-hmm.
then the ICD will be able to treat the arrhythmia effectively and stop the arrhythmia and return the rhythm to the normal rhythm, and solve the situation.
Yeah.
So that's why we put in ICD. So if we as a society, based on our risk models for each specific disease and for each specific individual, find that the risk for sudden cardiac death is such that we are not really sure that if we let the patient go just with medication, that the patient will survive for a certain amount of time, then as a society we will decide to implant an ICD. Knowing that the ICD will protect the patient, but also knowing that an ICD on the long run, on a lifetime basis, can also induce complications and also can lead to real problems for the patient. So there's always the balance that we have to make between the risk for sudden cardiac death that we can cover with the ICD and the risk for complications that are actually induced by implanting the ICD. And of course, on an individual basis, the risk is low, but if we look at populations of ICD patients on the long run, the amount of complications is not so low. So that's the balance that we have to make every time we make a decision.
What are complications, by the way?
That brings
like the wires or the leads, or what is a complication that is?
Yeah, so complications could be all sorts. So of course the ICD will give can give electrical shocks to convert a malignant arrhythmia towards the normal rhythm, but sometimes the algorithm of the ICD makes the wrong decision and will give a shock when it is not necessary. When there's a normal rhythm, for instance, when the patient is doing a physical exercise, is cycling, and suddenly the ICD thinks that there's an arrhythmia, and it will give a shock while the rhythm is completely normal. So that's unnecessary. That's called an inappropriate and, of course, unnecessary shock. This is really something that we like to avoid. Of course, when we implant the ICD, there can be all kinds of procedural complications, such as pneumothorax or hemothorax. There can be infections where the lead gets infected. If the system is infected by a bacterial infection, giving antibiotics will not solve the issue. Then we have to remove the entire system. Sometimes also the lead can break or can wear out where it no longer functions. Then we have to replace the lead. Sometimes there's device-related issues. So there's a whole bunch of really bad complications that we really like to avoid. And so this is also something that we have to take into account when making the decision. And of course, if the risk for sudden cardiac death is very, very high, the decision is very easy. But sometimes the risk for cardiac death is somewhere in the gray zone. And then, of course, we have to think what is best for the patient. Sometimes we do this also in a very open conversation with our patient, right, which we call a shared decision. So that's these are things that we do on a daily basis. Yeah. Brings me to the difference between ICD and CRT. So the ICD in itself will just protect against malignant arrhythmias. And in some cases, we have an electrical disease, such as Brugada syndrome or long QT syndrome, where there's merely electrical disturbances and no real heart failure. But in some diseases, such as in laminopathy, for instance, there's also heart failure, where there can be a asynchronous contraction between the left chamber and the right chamber, and when those chambers contract asynchronous, this is not preferable. This will also reduce the function of the heart, making it less effective. So in order to solve that, we can put in an ICD with an extra lead that goes also to the left ventricle, and we can give electrical impulses that from at both sides, to the left and the right ventricle together, resynchronizing the contraction of both chambers. And that can really augment the function of the heart, so really making the heart more effective in its pump function. So this can also be one way to treat heart failure. And of course, depending on the disease, depending on the profile, depending on whether there's heart failure or not, we will choose the platform of the ICD. We can do this either transvenous with a lead inside the vasculature towards the heart. We can also put an ICD under the skin with the lead above the sternum, above the bony thing in front of you at the chest. And there's a new platform which is called extravascular ICD, where we put the lead under the sternum, so under the bone of the chest in front of you. Yeah.
And the CRTD.
So the CRTD is the resynchronization device, where we it is an ICD. But also, so it's a cardiac resynchronization therapy ICD. So that is the device where we put one lead in the right chamber and one lead in the left chamber, and those will give pacing on both sides to resynchronize the contraction of both chambers.
I don't know if it's this kind of ICD, but isn't there a new kind of ICD that the wires don't have to go in the heart?
Yes, so these are the two latter platforms that I talked about. So you have the subcutaneous ICD. Yeah. So this is the ICD where that is put under the skin on the left hand side, and there the lead goes not inside the vasculature and not inside the heart, but it goes over the chest wall, under the skin of course, and over the sternum, so over the bone in front of you.
Right.
And then there's a second one which is quite new, which we call the EV ICD, or the extravascular ICD. Where again the device is put on the left-hand side under the skin, but where the lead goes over the wall of the chest, but under the sternum, so under the bony part of the chest wall in front of you. So it is actually inside the chest. But only the electrical part of the lead that can shock will be inside the chest, and the rest of it will go over the chest wall to the ICD box, which is under the skin on the left-hand side, and this is called EV ICD.